Now we are supposed to look at some layers of the scalp. There are some questions asked on the scalp, so we are talking about that. Actually, SCALP. What is SCALP? S for skin. And what is C for? Dense connective tissue. C for connective tissue. And what is A for? A for aponeurosis. Which aponeurosis? You know, there is a frontal muscle on the forehead and occipital muscle posterior. So there is occipitofrontalis muscle having aponeurosis. This is occipitofrontalis muscle aponeurosis. You mean to say flat tendon of the two muscles? Yeah, there is frontal muscle, flat tendon insertion. And this is the occipital muscle, flat tendon insertion. That flat tendon is called occipitofrontalis aponeurosis. So as for skin, yes. C for connective tissue, the dense connective tissue, right. And then you have the aponeurosis. Yes, what is L for? L. L is for loose connective tissue, loose connective tissue. And what is the P for? P for pericranium, which is periosteum. So P for pericranium, periosteum. Can we discuss some more details? Yes, you have to understand the true scalp is the first three things. So true scalp is the first three things means what will include there? The skin and the dense connective tissue and then the aponeurosis. And what is below that? Below that is a plane. It's a surgical plane. So below that is a plane, a surgical plane. Yes. And what do you do in that plane? In that plane, I can insert the tissue expanders. What do you insert? Tissue expanders. Why are you inserting tissue expander into this loose areolar connective tissue? Because this is a surgical plane and it's easy to access. So this is easy to access, and there you will access and put some tissue expander. Why are you putting tissue expander? I'll put the tissue expander so that the skin over that area will expand for surgical grafting. Then I can take surgical grafting. So before surgical grafting, you have to expand the skin, and that's what we are doing. Put some tissue expander and expand the skin and take the sample or take the specimen for grafting. Okay, so tissue expanders. What is still below that? That is the pericranium, actually periosteum, lining the skull bone. Can we have some more details? Yes, you are looking at this man now. What is this man? What is the problem? No problem, you're just looking at the man. And this is posterior direction and that is anterior direction. Now we have started dissection. You have started dissection on a living man? Yeah, of course. You do dissection on living person also. It doesn't mean that you do dissection only on cadaver. So this was a living man and you are doing the dissection. You can, but what I am showing you is actually a dissected cadaver now. So this is dissected cadaver, yes. And what is posterior? That is posterior, this is anterior, this is nose, and that is the ears. Okay, what do you want to see? I have dissected a cadaver now. Okay, then what did you see? The scalp. Actually, when you are talking about scalp, it has 5 layers. And what are the 5 layers? See, first is skin. And what is below that? It is dense connective tissue. And what is below that? Below that, you will see aponeurosis. What is that aponeurosis? Actually, there is a muscle on the front. Who is this? That is the frontalis muscle. There is a muscle on the back. Who is that? The occipitalis. So this is frontalis muscle and this is occipitalis muscle. And this is fronto-occipitalis aponeurosis, flat tendon. Yes. Okay, so there is skin, below that some dense connective tissue, then you have aponeurosis. Together, these are the true scalp. They are the true scalp, and below the true scalp you will have a plane of dissection or surgical plane. Are you talking about the surgical plane, loose areolar connective tissue, where you were putting some tissue expanders? Yes, that is where we put the tissue expanders to expand the overlying skin for surgical grafting. Okay, this is also called as danger area of the scalp. Why this is called danger area of the scalp? Because it is a space where you can have collection of blood, and if infection, then pus. So blood and pus can accumulate here. Yes. So what if the pus and blood is accumulating here in the loose areolar connective tissue? there are some veins passing through that, and that veins can carry the bacteria like Staph aureus, yes, Staph aureus skin infection, into the dural venous sinuses, causing meningitis. So you are telling that when there is some infection in the area, there is some blood and pus can be there, that can be carried by some veins into the dural venous sinus. I don't understand. Let us have another diagram for that. Yes, one more diagram is coming, but wait. This is danger area. What is deep to that? The last one. Who is the last one? That is the periosteum, which will be covering the skull bone itself. So S for skin, yes, A for this, C for the connective tissue, yes, A for aponeurosis, yes, and L for loose connective tissue, yes, loose areolar connective tissue, and then P is pericranium, scalp, yes, scalp, pericranium. Now remove the skull. What do you see deep to that? If I remove the skull, then what I see is the dura mater. And what if you remove the dura mater? Then I will see the arachnoid mater. And what is deep to the arachnoid mater? Deep to the arachnoid mater, I will see the subarachnoid space filled with CSF. And what is deep to that? Deep to that will be the brain. You mean to say that first it is the skull? Yes, of course, it is the skull, cranium, skull. And what if you go deeper? That is the dura mater. And what if you still go deeper? Arachnoid mater. And what if you still go deeper? If you are telling that this is the arachnoid mater, thin membrane, yeah, it is very thin membrane. Actually, it is transparent. So dura mater is opaque? Yes, dura mater is opaque. So dura mater is opaque. Yes, this is dura mater, it is opaque. But then this arachnoid mater is transparent. And what is deep to that? This space, subarachnoid space filled with CSF. And what is deep to that? That will be the pia mater covering the brain. That will be pia mater covering the brain. So you are showing that this is the brain. Yes. It will be covered by pia mater. Yes. And then there will be some space, the subarachnoid space. Yes. Then there will be arachnoid mater. Yes. And there will be dura mater. Yes. Then there will be the skull bone. Yes. And periosteum. Yeah, pericranium. And then you have aponeurosis. Yes. And then you have all the layers of scalp. Yes. Let us draw it the other way also. Which way we have to draw? You have to draw actually this way. What is this? S for skin, and C for connective tissue, A for aponeurosis, L for loose connective tissue, and P for pericranium. Scalp. SCALP, scalp. Okay, some veins are seen here. Yes, these veins are going to connect with dural venous sinus. Dural venous sinus, where the periosteum split into two layers. Yes, periosteum will split into two layers to enclose dural venous sinus. And it can have meningitis, can lead to the thrombosis within the dural venous sinus. So thrombosis within dural venous sinus, why? Bacteria has come from where? See, we have told that there is this loose areolar connective tissue where there can be pus and blood. This is the danger area. If that is the danger area, that is where you are putting the tissue expander also. Yes, some veins were passing. They are called emissary veins, and these emissary veins can be invaded. As the emissary veins are invaded, the bacteria can enter the dural venous sinus. And what are these veins within the skull? These veins which are within the skull are called diploic vein. They also drain into the dural venous sinus. So these are diploic vein within the diploi, the bone marrow of the skull. Yeah, diploi is bone marrow of the skull, and there you have diploic veins, and these diploic veins drain into the dural venous sinus. But that is not we are concerned with. We are concerned with loose areolar connective tissue having the invasion of the emissary veins. Emissary veins are intracranial, extracranial connection. So emissary veins are intracranial, extracranial extension. You mean to say extracranial infection can move intracranial? Yes, that is the point. As we are drawing this diagram, understand skin and connective tissue and aponeurosis and loose areolar connective tissue, and then there is pericranium. So this is skin, yes, and this is some dense connective tissue? Yes, it is dense connective tissue. What is the use of knowing it is dense? The use of knowing dense is any blood vessels which are there in this connective tissue, maybe artery, or maybe it is the vein, or maybe it is some nerve also. So you're telling that in this connective tissues there is neurovascular bundle? Yeah, there is neurovascular bundle. So there is some neurovascular bundle in the dense connective tissue. Yes. So what is the importance of knowing that it is dense? Actually, it is quite dense. Lot of fibers are there, and those fibers are adherent to the arteries. So fibers are adherent to arteries. Then whenever there is a bleeding, those arteries find difficult to close. You mean to say profuse bleeding? Yes, profuse bleeding. Scalp bleeding is profuse bleeding. It keeps on bleeding. Why it keeps on bleeding? Because the vessels cannot retract. Why the vessels cannot retract? Because they are adherent to the dense connective tissue. So you're telling that there is some neurovascular bundle under the skin. Yes. And that neurovascular bundle, the arteries become adherent to the dense connective tissue, the fibers. Yes. Which do not let the arteries to retract and close. Yeah, they gape. The arteries cannot retract and they keep gaping, so a lot of blood keep coming out. So they cannot close. No, it is difficult. Because of that, there is profuse bleeding. So skull bleeding is quite profuse. And what about the aponeurosis? Aponeurosis, we have already told there is one muscle on the front, frontal muscle, and posterior, the occipital muscle. So this is occipitofrontalis aponeurosis. And what was deep to that? Is the plane where you put the tissue expander. So here we put the tissue expander. I think this is the plane, which is surgical plane, where you have some pus and blood accumulated. Yes, it can. Some pus and blood can accumulate here. And what is this? This is pericranium. Or you can say periosteum. Yeah, periosteum. Pericranium, periosteum, because after that you have the skull. This is the skull. If you say this is the skull, I think skull will have some bone marrow. Yeah, bone marrow, that is called diploid. The bone marrow, which is called diploid. It's a flat bone having diploid. So you're telling this is skin. Yes. And connective tissue, dense connective tissue. Right. With profuse bleeding there. Second layer. Yes. And third is the occipitofrontalis aponeurosis. Right. Fourth is the danger area. Yes. Why it is danger area? It is danger area because you see some extracranial, intracranial veins now. What is this extracranial, intracranial veins? Actually, there is some extracranial, intracranial communications. Are you talking about the emissary veins? Where are the emissary veins going? They will go into this. You remember, there was this dura mater splitting into two layers. And when the dura mater split into two layers, what is enclosed? That is dural venous sinus. So this is dura mater, which will split into two layers to enclose the dural venous sinus, and this is emissary vein. Extracranial, intracranial communication. So it was passing through danger space. And in the danger space, what was there? In the danger space, there can be pus and blood. And what is that pus and blood doing? See, this is the loose cellular connective tissue, layer number 4, where we are having some pus blood that will invade the emissary vein. And as it will invade the emissary vein, what will happen? Bacteria inside. So that is why it is called danger area of scalp. Yes, layer number 4.